This dark pigment staining of the colonic wall is known as melanosis coli, the term initially established by Dr. Rudolf Virchow in 1870. While the name has persisted, it has long been recognized that the pigment staining is not due to increased melanin deposits as initially thought, but instead due to lipofuscin, a cellular degradation product. The lipofuscin is found in histiocytes, or macrophages, and is thought to represent degradation products from cells undergoing apoptosis. The association between melanosis coli and the use of cathartics that contain the active ingredient anthraquinone has been established. In laboratory settings, anthraquinones cause apoptosis of guinea pig enterocytes, leading to lipofuscin accumulation. The pigment accumulation is documented to be reversible if intake of the offending agent is avoided. Melanosis typically is most intensive in the cecum and diminishes in intensity down the length of the colon. Characteristically, the terminal ileum is devoid of any pigment uptake, as seen here. Okay, so why this pattern? What can we learn about melanosis by looking closely at this endoscopic picture? First, on low power, we can identify lymphoid aggregates and see that they are devoid of any lipofuscin pigment. On high power, again, we can see that these lymphoid aggregates are free of lipofuscin and are in fact surrounded by pigment-laden histiocytes which crowd around the periphery. Back again to low power view, we can clearly see that the pigment is located entirely in the lamina propria, sparing the pits as well as the lymphoid aggregates. Thus, returning to the endoscopic picture, we now understand that the pigment-free areas here are the lymphoid aggregates, and that the surrounding brown halo is comprised of pigment-laden histiocytes. Furthermore, with magnification, we can appreciate this geographic pattern of white dots, which we know are the epithelial pits. The brown staining around the pits represents lipofuscin-laden histiocytes in the surrounding lamina propria. This second example demonstrates even more intense lipofuscin accumulation in the colon. Here the cecal epithelium is so pigment congested that it is difficult for the endoscope processor to generate adequate illumination. This polypoid structure stands out due to the absence of pigment. Because it is suspected of being a polyp, it is removed by the cold snare technique and sent for pathologic examination. Pathology demonstrated this to be comprised of prominent fibroadipose tissue of the submucosa. Prominence of fibroadipose in the submucosa can be seen as a normal finding in the right colon. Unanswered questions remain about this common and commonly ignored finding. Why is the small bowel completely spared of pigment? Does everyone who consume these anthracene-containing laxatives develop congestion of lipofuscin, or is this a consequence of some metabolic or enzymatic defect? And finally, what is the relationship between these lymphoid aggregates and their halo of congested histiocytes? Who attracts who?